The next article is entitled Efficacy, Safety and Tolerability of Levonorgestrel Ethinyl Estradiol Transdermal Delivery System, Phase 3 Clinical Trial Results. This single-arm study sought to determine if a levonorgestrel 120 micrograms per day and ethinyl estradiol 30 micrograms per day contraceptive combination delivered via a transdermal patch would be an effective means of contraception. They enrolled over 2,000 patients who demographically resembled the US contraception using population and evaluated them over 13 cycles, in essence 1 year. Each patient applied an active patch weekly for 3 weeks, followed by a patch-free week. They found this method of contraception delivery was effective, safe, and tolerable in preventing pregnancy, although efficacy was reduced if the BMI was greater than 30. So the take-home message: a patch containing combined levonorgestrel and ethinyl estradiol is an effective and acceptable alternative method of contraceptive administration. The next article is entitled Levonorgestrel versus Copper Intrauterine Devices for Emergency Contraception from the Massachusetts Medical Society. Currently, only IUDs containing copper are available for emergency contraception. The authors of this study sought to determine if the levonorgestrel containing IUD was or was not inferior to the copper containing IUD for this specific purpose. They conducted a randomized trial of over 700 participants, all having had at least one episode of unprotected intercourse in the preceding 5 days, and then looked for a positive pregnancy test within 1 month. They found that the levonorgestrel IUD was not inferior to the copper IUD. So the take-home message: the levonorgestrel IUD should be considered as an additional option for emergency contraception. Our next GYN MOC article is entitled Levonorgestrel Releasing Intrauterine System versus Endometrial Ablation for Heavy Menstrual Bleeding. This multi-center randomized controlled trial registered 270 women with abnormal uterine bleeding acceptable to the trial requirements. They randomized them into 2 groups of treatment, one receiving levonorgestrel releasing IUD and the other receiving endometrial ablation. They then followed them over 24 months to determine the comparative effectiveness of these treatments. They found that although both groups had a large and significant decline in menstrual blood loss, the loss was substantially greater with endometrial ablation. They also noted that patients receiving the levonorgestrel IUD were significantly more inclined to require further subsequent surgical treatment, 27% for the IUD group versus 10% for the ablation group. So the take-home message: both levonorgestrel IUD and endometrial ablation are effective in treating abnormal uterine bleeding, but patients receiving the IUD are more likely to require additional treatment. The next article is entitled Efficacy and Safety of Oral Ibrexafungerp for the Treatment of Acute Vulvovaginal Candidiasis, a global Phase 3 randomized placebo-controlled superiority study. The authors of this international multi-center trial randomized patients to Ibrexafungerp, a 1-day oral agent, versus placebo for the treatment of acute vulvovaginal candidiasis in patients 12 years of age and older. Endpoints included complete eradication as well as lesser degrees of improvement. They found that Ibrexafungerp was superior to placebo for both complete eradication as well as improvement of symptoms, and the treatment was well tolerated. So the take-home message: Ibrexafungerp is superior to placebo for the treatment of vulvovaginal candidiasis. The next article is an ACOG practice bulletin and is entitled Prevention of Venous Thromboembolism in Gynecologic Surgery, And since this is already a summary article, no further contraction will be feasible. Venous thromboembolism, or VTE, which typically occurs within 24 to 72 hours of surgery, is a major cause of post-operative complications, both acute and chronic. In order to reduce its incidence, preoperative patients should be assessed for both VTE risk as well as bleeding risk. The Caprini scoring system is used to assess VTE risk. Examples of various clinical scenarios and their respective Caprini score are provided. Thereafter, once one's determined the risk factors, one must in addition assess risk factors for increased bleeding. So getting back to the Caprini score, this is a system that scores out of 5 points, although there's no condition which is allocated with 4 points. So you can get 1, 2, 3, or 5 points. One gets 1 point for any of the following: age 41 to 60, minor surgery, BMI greater than 25, swollen legs or varicose veins, pregnancy and postpartum, birth control pill, hormone replacement therapy, or estrogen receptor modulator usage, sepsis, patient on bed rest, and a few miscellaneous medical conditions. Those all score 1 point. Factors scoring 2 points are age between 61 and 74, laparoscopic or major open surgery lasting more than 45 minutes, and malignancy. 3 points will be scored for age greater than 75, personal or family history of VTE, and hereditary and congenital acquired hemophilias. Again, there are no conditions which score 4 points, and 5 points will be scored if there's a hip, pelvis, or leg fracture. The cumulative score will then place the preoperative patient into one of 3 VTE risk categories. Cumulative Caprini score of 1 or 2 will be low risk, where the VTE risk is in fact 1.5%. A cumulative Caprini score of 3 to 4 would be moderate risk, where the VTE risk is about 3%. And with a cumulative Caprini score of 5 or higher, this would be regarded as high risk, where the risk of VTE is 6%. The method of VTE prophylaxis is then based on the degree of risk. This determination should be further modified, as mentioned previously, by considering risk factors for bleeding complications. These risk factors include concomitant use of anticoagulants, acute stroke, malignancy, previous major bleeding, and uncontrolled systemic hypertension. Now let's look at the 3 risk groups. For low risk patients, mechanical thromboprophylaxis is recommended. Here, intermittent pneumatic compression is preferred, and this is as effective as low dose unfractionated heparin. Graduated compression stockings can be used, but they are less preferred. That's low risk patients. For moderate VTE risk patients with a low risk of bleeding complications, one can use mechanical options, which comprise intermittent pneumatic compression, which again is preferred, or one can give low dose unfractionated heparin or low molecular weight heparin. Pharmacologically, low dose, also known as prophylactic dose unfractionated heparin, this is given subcutaneously from 2 hours pre-op up until 8 to 12 hours post-op. The advantage is it's low cost and it's acceptable in patients with kidney failure. Disadvantages, however, it may increase intra and post-operative bleeding. So that's low dose unfractionated heparin. The next option is low molecular weight heparin. Here the advantages include less frequent dosing, decreased risk of thrombocytopenia such that platelet testing is not necessary, decreased risk of major intra-op and post-op bleeding, and decreased incidence of heparin-induced thrombocytopenia. The incidence is 1.5%, associated with low dose unfractionated heparin, but only 1% with low molecular weight heparin. Disadvantages of low molecular weight heparin include the fact that it's problematic for patients with kidney failure, its cost, and it's not fully reversible with protamine sulfate. If the patient is at high risk for bleeding complications, in other words, she's got moderate VTE risk but high bleeding complication risk, then pharmacological therapy should be omitted. Next, we come to patients who are at high VTE risk and average bleeding complication risk. Combination mechanical, preferably intermittent pneumatic compression again, and pharmacological prophylaxis with low dose heparin or low molecular weight heparin is recommended. If there is high VTE risk and high bleeding complication risk, then pharmacological prophylaxis should be admitted until the bleeding risks decline. Extended duration prophylaxis with low molecular weight heparin after discharge is recommended, and this should continue for 28 days post-op in those undergoing surgery for cancer. Fondaparinux and or mechanical prophylaxis is an alternative for those undergoing GYN surgery who are at high VTE risk but not high risk for bleeding complications, and where low molecular weight heparin or unfractionated heparin is either not available or contraindicated. Similarly, if in addition the patient is at high risk for bleeding complications, fondaparinux should be withheld until the bleeding complication risks decline. Next, one can also consider a new group of so-called direct oral anticoagulants. This is a new group of oral agents, rivaroxaban, apixaban, and dabigatran, which can be taken orally. They are more effective than low molecular weight heparin and have rapid onset and clearance. They are recommended for patients undergoing gynecological cancer surgery. And now for some miscellaneous considerations. For patients undergoing minimally invasive surgery, mechanical prophylaxis is sufficient in most cases, especially if high VTE risk factors are present, when the addition of pharmacological prophylaxis should be considered. Patients with perioperative VTE should not be routinely tested for thrombophilias, since a positive finding will not alter treatment. Rather, one should screen for risk factors and, if present, refer to a specialist. Combined oral contraceptive pills should only be discontinued prior to major surgery. However, if immediate post-op ambulation is expected, this is not necessary. When discontinuation is undertaken, this should occur 4 to 6 weeks prior to surgery and can be restarted when the patient returns to normal activity. It is not clear if patients on hormone replacement therapy should discontinue their treatment, since although the risk of VTE is elevated, the increase is small. Obese patients requiring pharmacological prophylaxis should receive higher doses than usual. And finally, for patients having regional anesthesia, as opposed to low molecular weight heparin, which is associated with spinal or epidural hematoma, low dose unfractionated heparin may be administered, provided this is done no less than 12 hours prior to catheter insertion and at least 4 hours after catheter removal. The next article is entitled Prophylactic Negative Pressure Wound Therapy After Laparotomy for Gynecologic Surgery. The authors of this randomized controlled trial collected over 600 patients undergoing laparotomy for malignancy or presumed malignancy surgery. They included obese patients as well as patients whose surgery subsequently revealed the pathology to be benign. After an interim evaluation of the data, they found no overall significant improvement in wound complication rate, although there was an increased incidence of skin blistering in the negative pressure wound therapy group. The study was consequently halted. So the take-home message: overall, negative pressure wound therapy has no advantage over standard gauze closure in patients undergoing laparotomy. The next article is entitled Recommended Standardized Anatomic Terminology of the Posterior Female Pelvis and Vulva, based on a structural medical literature review. These authors performed a literature review regarding terminology relating to the posterior female pelvis and vagina and related it to the accepted Terminologia Anatomica standard. They addressed 40 terms from multiple articles on a Medline search, as well as abstracts and book chapters, and found almost 500 words to describe these specific structures. With such tremendous variability, they suggested the adoption of 11 new terms to minimize much of this variation. These are anal sphincter complex, genital crural fold, interlabial sulcus, posterior vaginal compartment, sacrospinous coccygeus complex, greater vestibular duct, anal cushions, nerve of the levator ani, labial fat pad, and deep post-anal space. They comment that the definition of rectovaginal fascia remains deficient and still needs to be better defined. The take-home message: posterior female pelvis and vagina nomenclature is currently not standardized, and the authors make several anatomical nomenclature recommendations to improve uniformity. The next article is entitled Relugolix, an oral gonadotrophin releasing hormone receptor antagonist, reduces endometriosis-associated pain in a dose-response manner. A randomized, double-blind, placebo-controlled study. The authors of this study sought to evaluate the effectiveness, that is, the reduction in pain, of an oral GnRH receptor antagonist in comparison to placebo and intramuscular GnRH agonists in patients with endometriosis. Those receiving Relugolix were divided into 3 groups, each receiving either 10, 20, or 40 milligrams daily. They found that Relugolix was efficacious and safe, especially in a dose-response manner. At 40 milligrams daily, Relugolix was comparable to intramuscular leuprorelin. Take-home message: Relugolix, an oral GnRH antagonist at a dosage of 40 milligrams daily, is an acceptable alternative to monthly leuprorelin injection. The next OB article is entitled Evaluation of Complications in Postpartum Women Receiving Therapeutic Anticoagulation. The authors of this multi-center retrospective cohort study sought to determine the relationship between the timing of reinstitution of postpartum anticoagulation in relation to the development of major hemorrhage and wound complications, as well as minor complications. They evaluated over 230 such cases and found that the incidence of complications was higher when the postpartum interval was shorter, especially less than 9.25 hours in the case of a vaginal delivery and 15 hours for those delivering by C-section. So the take-home message is that reinstitution of anticoagulation should occur after 9.25 hours with vaginal delivery and after 15 hours with caesarean section delivery. The first OB article is entitled Foley bulb added to an oral misoprostol induction protocol, a cluster randomized trial. The authors divided over 2,000 singleton-term pregnancies requiring induction with oral misoprostol into 2 arms, with one receiving oral misoprostol alone and the other with the addition of a Foley balloon. They found that the addition of the Foley balloon did not increase the vaginal delivery rate, but did increase the incidence of chorioamnionitis. So the take-home message: the addition of a Foley balloon to misoprostol for induction at term is not beneficial. The next article is entitled "The Case for Standardizing Caesarean Delivery Technique, Seeing the Forest for the Trees." The authors of this commentary article reviewed the literature and updated the current understanding for standardizing the optimum method of caesarean delivery. They noted the following: abdominal entry should be with sharp subcutaneous and fascial dissection and with blunt entry into the peritoneum. A bladder flap should be omitted. The uterine incision should be via a 2 to 3 centimeter transverse incision followed by blunt entry and cephalad-caudad extension. Wiping of the intrauterine cavity should be undertaken only if retained membranes are noted. Routine cervical dilatation should be omitted. The uterus should be exteriorized for closure of the incision, which should be performed with a single layer. Intra-abdominal irrigation should be omitted, as should peritoneal closure, which should be omitted, and reapproximation of the rectus muscle, which again should be omitted. Additionally, routine glove changing should be omitted. Fascia should be closed with continuous delayed absorbable suture. One should perform subcutaneous irrigation. One should only close subcutaneous tissues if the thickness is greater than 2 centimeters. And one should close skin with subcuticular absorbable monofilament suture. And the take-home message: since this is already a summary article, no further contraction is feasible. The next article is entitled "Top 10 Pearls for the Recognition, Evaluation and Management of Maternal Sepsis." This article is from a clinical expert series and presents the optimal management for maternal sepsis in pregnancy. Maternal sepsis should be regarded as an obstetric emergency. Rapid diagnosis and treatment is crucial to reduce the high mortality rate associated with this condition. One should aim to begin antibiotic therapy in the first hour of presentation, and the authors provide the following recommendations. 1. Maintain a high index of suspicion. 2. Have a rapid bedside tool to assist in detection and diagnosis. For example, the QSOFA tool. This stands for QSOFA, Quick Sepsis-Related Organ Failure Assessment, the so-called QSOFA tool. Number 3, implement immediate therapeutic modalities with an option to rapidly progress to additional therapeutic options. 4, perform tests and studies to determine the etiology. 5, be familiar with the various organisms identified in this condition, the typical source or location, and clinical presentation. In particular, be aware that group A streptococcus can cause rapid mortality. 6, use antibiotics most suited for the suspected offending organism. 7, commence rapid rehydration if the lactate level is greater than 4 millimoles per liter, or if the mean arterial pressure is less than 65 millimeters of mercury. Number 8, ongoing escalation of care is critical to reduce mortality. 9, once the patient is stable, move to eliminate the offending cause, that is, treat the primary problem. And finally, number 10, work to reverse or minimize any related obstetric issues. The take-home message: since this is already a summary of a review article, no further contraction is feasible. The next article is entitled "Vaginal Delivery After External Cephalic Version in Patients with a Previous Caesarean Delivery, a Systematic Review and Meta-Analysis." The authors of this literature search article sought to assess the rate of vaginal delivery following successful external cephalic version for breech presentation in patients with and without a history of prior caesarean section delivery. They included 8 studies with a total of almost 15,000 such patients, and they found that both groups of patients had similar successful external cephalic version rates. The subsequent successful vaginal delivery rate, however, was lower in the group with a history of a prior C-section, 83% versus 97%. The take-home message then is that patients with a prior history of C-section and who present with a breech at term have the same successful external cephalic version rate and a slightly lower subsequent vaginal delivery rate when compared to those without a history of prior C-section. The next article is entitled Pregnancy-Associated Deaths Due to Drugs, Suicide, and Homicide in the United States from 2010 to 2019. The authors of this study reviewed almost 12,000 pregnancy-associated deaths among 33 states within the United States over a 10-year period. They found that approximately 12% of all such deaths were due to drugs, 5% due to suicide, 5% due to homicide, and 60% due to obstetric causes. The total death rate increased almost 200% over the study period. The take-home message: suicide, drug, and homicidal deaths related to pregnancy constitute more than 20% of all pregnancy-related deaths. The next article is entitled Semi-Autonomous Treatment Algorithm for the Management of Severe Hypertension in Pregnancy. This retrospective cohort study sought to evaluate the effectiveness of a semi-autonomous algorithm applied to the ACOG guidelines for the treatment of severe hypertension in pregnancy. They evaluated almost 1,000 patients from a single institution to determine if the time to initial dose of treatment was improved. They looked at a time interval of 15, 30, and 60 minutes. They found an increase in the number of patients receiving a first dose of antihypertensives in the 15 and 30-minute group, but not in the 60-minute group. The take-home message then is that a semi-autonomous algorithm can speed up time to initial treatment based on ACOG guidelines for the management of severe hypertension in pregnancy. The next article is entitled Society for Maternal-Fetal Medicine Consult Series number 56, Hepatitis C in Pregnancy Updated Guidelines. Approximately 2% of pregnant women in the United States are infected with hepatitis C, and this status carries a 5% risk of transmission to the fetus either in utero or peripartum, which can lead to adverse neonatal outcomes. The Society for Maternal Fetal Medicine thus makes the following recommendations. Although increased antenatal testing is not suggested, third trimester evaluation for IUGR is an option. Patients with intrahepatic cholestasis of pregnancy or elevated bile acids in early pregnancy should be screened for hepatitis. All pregnant patients should be screened for hepatitis C with hepatitis C antibodies. If positive for hepatitis C, patients should be screened, if not already done, for STDs including HIV, syphilis, gonorrhea, and hepatitis B, and they should receive vaccination against hepatitis A and B. With respect to management in labor, the Society for Maternal-Fetal Medicine recommends against C-section solely for hepatitis C positive status and the avoidance of internal fetal monitor use and artificial rupture of membranes unless absolutely warranted. Finally, hepatitis C positive status should not affect breastfeeding recommendations. The take-home message: since this is already a summary article, no further contraction is feasible. The next article and committee opinion issued by ACOG is number 824 and is entitled Elder Abuse and Women's Health. Elder abuse is a single or repeated action or inaction which can result in harm to those over 60 years of age. It disproportionately affects women in up to 10% of this age group. ACOG supports OBGYNs screening the elderly by looking for evidence of neglect, emotional abuse, physical abuse, and sexual abuse. Warning signs for diagnosing elder abuse include the following: poor personal hygiene and public presentation, loss or forgotten daily assists, for example, hearing aids or reading glasses, inappropriate dress, and poor nutrition as well as dehydration. When detected, this must be reported in most states to Adult Protection Services. Physicians are also encouraged to educate all those interacting with the elderly, such as care providers, family, etc., regarding elder abuse. And since this is already a summary article, no further take-home message contraction is feasible. The next MOC article is also an ACOG Practice Bulletin number 224 and is entitled Diagnosis and Management of Vulvar Skin Disorders. This publication addresses the most common vulvar symptoms of pain and pruritus caused by an inflammatory process, and these include contact dermatitis, an allergic response accounting for 50% of such patients, lichen sclerosus chronicus, which presents as a non-scarring condition with intense pruritus accompanied by itching and rubbing, especially at night. It can be primarily present or secondarily present to other vulvar conditions such as applied topical products, and it is commonly associated with a personal or family history of seasonal allergies and asthma. Next is lichen sclerosus, which is a scarring condition whose etiology is unknown, and it's most prevalent in prepubertal girls and postmenopausal women. Finally, there's lichen planus. This is a scarring condition affecting skin, oral mucosa, and vulvovaginal areas, whose etiology too is unknown. It affects predominantly postmenopausal women. Now, the differential diagnosis may include common infective causes of vulvovaginitis such as Candida, BV, and Trichomonas, as well as herpes simplex virus, Paget's disease, hidradenitis suppurativa, and genitourinary syndrome. Conditions such as VIN are addressed in other practice bulletins. With respect to the workup, this includes an extensive history and physical and an evaluation of any vaginal discharge if present. If warranted, a fungal culture and STD panel should be performed. If specific diagnoses are ruled out, one is left with a diagnosis of vulvodynia. A vulvar biopsy may be considered if the lesions are atypical, for example, new pigmentations, bleeding, ulceration, or fixation to underlying tissues. If there is a concern for malignancy, in the presence of immunocompromise, where the diagnosis is uncertain, or when there is inadequate response to therapy. Let's discuss now the individual diagnoses. Firstly, contact dermatitis. This presents with erythema, which may range from mild to severe and includes swelling, excoriations, erosions, and ulcers. The management may be regarded as preventative or therapeutic. Firstly, prevention. One should avoid irritants and allergens, avoid soap usage on the vulva, and clean with water only. Use unscented 100% cotton, fragrance-free menstrual pads and clothing, and apply adequate lubrication for intercourse. With respect to treatment, local steroid ointment is recommended with concentration depending on severity. Additionally, one can give antihistamines and, if warranted, antidepressants. Next is lichen simplex chronicus. This diagnosis is typically made clinically and appears with plaques of erythema and scaling. Sometimes excoriation is present. Treatment is somewhat similar to that of contact dermatitis. However, higher doses of steroids are warranted. Next is lichen sclerosus. This appears clinically as white plaques, often associated with ecchymoses or purpura. The skin is thin, white, and wrinkled with a cigarette paper-like appearance. The genital mucosa is typically spared. A biopsy is commonly performed to confirm the diagnosis and also to rule out the approximately 5% risk of underlying vulvar squamous cell carcinoma. Initial treatment is with high-potency topical corticosteroid ointments such as clobetasol. Once good control is achieved, steroid potency can be reduced to a level that maintains control. In those cases where control is not achieved, one should confirm that the diagnosis is correct, that is, perform a biopsy if one has already not yet been done. Also, one should consider possible urinary incontinence or superimposed bacterial or fungal infection as an aggravating issue. For those who are resistant to therapy, one can consider intralesional steroid injections, and if this does not work, topical calcineurin inhibitors may be given. If still no improvement, one should refer to a vulvar specialist. Finally, we discuss lichen planus. This classically presents with papulosquamous lesions, which are white and fern-like. It may also appear as a pink color, and the papules may be poorly demarcated. This often involves the posterior vestibule, and the vaginal mucosa may also be involved with erosive patches. The prognosis for lichen planus is poor and complete control rare. Treatment is similar to that for lichen sclerosus, and the mainstay of treatment is high-dose corticosteroid topical treatment. Finally, with respect to a take-home message, since this is already a summary article, no further contraction is feasible. Our next article is entitled Association of Menopausal Hormone Therapy with Breast Cancer Incidence and Mortality During Long-Term Follow-up of the Women Health Initiative Randomized Clinical Trials. These authors used participants from the Women's Health Initiative study involving over 27,000 women to evaluate the incidence and mortality of breast cancer amongst patients receiving 1. Estrogen with progesterone versus placebo in those with an intact uterus, and 2. Those receiving estrogen alone versus placebo in those who had had a prior hysterectomy. They found that in the intact uterus group, those who received estrogens with progesterone had a higher incidence of breast cancer, but with no difference in mortality. In contrast, with the hysterectomized group, estrogen alone had a lower incidence, again when compared with placebo, of breast cancer, as well as a lower mortality rate. So the take-home message: in comparison to placebo, postmenopausal women with a uterus receiving estrogen with progesterone are more likely to develop breast cancer. However, those who have had a hysterectomy and who received estrogen alone were less likely to develop breast cancer, and they also had a lower mortality. The next MOC office article is entitled Buprenorphine Patch as a Bridge to Sublingual Treatment of Opioid Use Disorder in Pregnancy. Timing of initiation or induction of buprenorphine administration for opioid withdrawal is critical to achieve successful withdrawal and thereby improve obstetric outcomes. Initiating too soon or too late will increase adverse effects. The authors of the study, comprising just 8 patients, used a transdermal buprenorphine patch which provides microdoses of buprenorphine to bridge the gap to sublingual buprenorphine. The microdose option allows for improved therapy induction during times of moderate opiate withdrawal, which is the optimum time to commence such treatment. They found that most patients successfully bridged from the patch to sublingual therapy and suggest further study for this therapeutic option is warranted. The take-home message: transdermal patch may be beneficial in filling the gap to get patients with opioid disorder onto successful sublingual therapy. The next article is entitled Menopause, Transition and Cardiovascular Disease Risk: Implications for Timing of Early Prevention, a scientific statement from the American Heart Association. The authors of this lengthy scientific statement update our current understanding regarding transitioning through menopause and its effect on cardiovascular disease. Reproductive aging throughout life transitions through 7 stages, with the perimenopausal phase being the most symptomatic. Menopausal transition is characterized by symptoms such as vasomotor imbalance, sleep disturbance, and depression or anxiety. Later age of menopause is associated with increased overall longevity, increased premenopausal weight, and decreased physical activity and alcohol consumption. Conversely, early menopausal age is associated with poor cardiovascular health. Cardiovascular health is characterized by the American Heart Association using 7 parameters, most of which, like metabolic syndrome, are more commonly and adversely prevalent in menopause. These 7 parameters are as follows: BMI, which is higher in middle-aged and menopausal women; physical activity, and this is lower in menopausal patients; smoking. Now here, while the incidence of smoking is not significantly different in the menopause, the effect of smoking is increased in menopausal women. And the last 4 parameters are diet, cholesterol, blood pressure, and fasting glucose level. Commencing hormone replacement therapy prior to age 60 or within 10 years of menopause is associated with a significant reduction in coronary heart disease risk. And finally, transdermal, as opposed to oral HRT, is associated with less cardiovascular disease complications. The take-home message: since this is already a summary statement, no further contraction is feasible. The next article is entitled Mifepristone Combination Therapy Compared with Misoprostol Monotherapy for the Management of Miscarriage, a cost-effective analysis. The authors of this study evaluated the cost of medical management of miscarriage using misoprostol alone versus misoprostol in combination with mifepristone. They found a cost saving with combination therapy over monotherapy of 6 to 20%. They thus recommend combination therapy to reduce the cost of medical management of miscarriage. So the take-home message: for the medical management of miscarriage, combined therapy comprising mifepristone and misoprostol is preferred to misoprostol alone from a cost-benefit point of view. The next MOC article is entitled Oral Contraceptive Use and Ovarian Cancer Risk for BRCA1 and 2 mutation carriers, an international cohort study. This retrospective study reviewed over 6,000 patients who were BRCA1 or 2 mutation carriers to evaluate in depth the benefits of oral contraceptive use on ovarian cancer risk. The benefit is that this would give care providers more information regarding counseling their patients. They found that BRCA1 mutation carriers using oral contraception had a significant reduction in ovarian cancer risk. This reduction was related to the length of time the patient had been using oral contraception, and this benefit lasted for over 15 years since last use. Similar conclusions could not be drawn for BRCA2 carriers due to the limited sample size. So the take-home message: oral contraceptive use in BRCA1 mutation carriers reduces the risk of ovarian cancer in this population, and the benefit is long-lasting. The next article is actually the first in the ACOG Clinical Practice Guidelines series and is entitled Osteoporosis Prevention, Screening and Diagnosis. And since this is already a summary article, no further contraction will be feasible. Osteoporotic fractures are most common in the United States amongst white and Hispanic races. 50% of women over 50 years of age will experience an osteoporotic fracture. Racial disparities in screening and treatment exist. However, clarification if this is due to unequal opportunity or unequal outcome is not provided. Risk factors include increasing age, a history of hip or spine fracture, a BMI of less than 20, smoking, excessive alcohol use, as well as various medical conditions such as diabetes, HIV, and premature menopause, as well as various drugs such as anti-epileptics, GnRH agonists and antagonists, as well as heparin. Bone density is best assessed with a DEXA scan of the hip and lumbar spine. and one looks at the T-score and the Z-score. With respect to the T-score, this compares the patient's bone density to a healthy young adult population. Osteoporosis is defined as a T-score standard deviation of greater than minus 2.5, or in a postmenopausal woman, the presence of a history of a fragility fracture, including vertebral fracture, or a T-score in the osteopenia range, which will be discussed shortly, coupled with an increased risk using a risk assessment tool, for example, the FRAX index. And osteopenia is defined as a T-score of between minus 1.0 and minus 2.5 standard deviations. A Z-score, on the other hand, compares patients' bone density to that of a similar age, sex, and ethnicity. It's used to determine those at risk for secondary osteoporosis. A Z-score greater than minus 2 standard deviations is regarded as abnormal. Prevention strategies include the following: moderate to high intensity and weight-bearing exercise, averaging per week approximately 30 minutes of moderate intensity and 15 minutes of high intensity exercise per day. Vitamin D and calcium supplementation. Now, in this regard, while the United States Preventative Services Task Force states there is insufficient evidence to recommend for or against such supplementation for non-at-risk women, the Institute of Medicine suggests an recommended daily allowance, or RDA, of 1,000 milligrams per day of calcium for ages 19 through 50 and 1,200 milligrams per day if over age 50, as well as vitamin D 600 international units per day if age less than 70 and 800 international units per day thereafter. Clinical evaluation should comprise documenting height change, where a loss of more than 2 centimeters in less than 3 years warrants further vertebral fracture evaluation. Bone mineral testing should begin at age 65, preferably femoral neck and lumbar spine, or sooner if deemed to additionally have risk factors for osteoporosis. Guidelines are not provided regarding the interval for repeat testing. However, ACOG recommends a repeat scan not less than 2 years later if the original test was near treatment thresholds or in the presence of significant risk factor changes. Use of a risk assessment tool, for example, the FRAX index, is recommended. This is used to assess fracture risk in the ensuing 10 years for women aged 40 years and up. It is particularly beneficial to determine those postmenopausal women who require bone mineral density testing if prior to age 65 with risk factors, or to determine the need for treatment in those with osteopenia. Parameters included within the FRAX index include age, sex, height, weight, prior fracture, family history of hip fracture, steroid, smoking or alcohol use, and the presence of secondary causes of bone loss. And finally, fall prevention should be encouraged through improvements in muscle strength, vision, balance training, and environmental fall risk evaluation.